Hi, good evening, everyone. Hi, Jeff and Albert and everyone.
Good evening.
Hi. So, Jeff, it looks like we've got 27 participants. I guess maybe Albert and I will just do a brief introduction, hand over to you as the host.
Yeah, perfect.
That maybe also allow a few other people on board. So does that make sense, Albert? You in agreement? Okay, cool.
Perfect.
All right. Hi everybody. Good evening. It's Michael and Albert here, just to welcome you to our U of T Spine Program Journal Club. That'll be hosted by Dr. Jeff Wilson at St. Michael's Hospital. And Jeff will introduce the fellows and the theme for this evening. Just want to do a shout out to Nadia Jabber, our program manager, for putting together all of the logistics, and the reference to the materials is also in the chat line. So big appreciation, and also big appreciation to our various supporters, Department of Surgery, Division of Neurosurgery, Orthopedics, as well as our various industry sponsors. Albert, over to you.
It's terrific. So good evening, everyone. And this is part of our sort of academic calendar of events as part of the U of T Spine Program. And so I'd like to welcome everyone to our Journal Club this evening. Special thanks to Jeff and the St. Mike's Group for really taking the lead to help guide us through the topic this evening, which will focus on disc herniation and a very common condition that obviously many of us as spine surgeons in training or in practice deal with and see on a regular basis. Special thanks to Johann, Sho, Doron, and Martin for presenting the papers this evening. I think looking at the backgrounds, I see Martin's been in the library vividly reading and getting ready for journal clubs. He's got all the books and everything already, and so I look forward to a great discussion to follow some of the papers. There obviously is a lot of still a lot of clinical practice variations in terms of surgical techniques and what to do in some challenging cases. Special thanks to Nadia again for helping to organize this group, to the faculty from around the city, as well as the other. We've got researchers, trainees joining us, as well as our industry partners and supporters, Medtronic, Stryker, Dupree Synthes, Sarah Pedix, Zimmer Baumet, and Baylis Medical and Anchornaut. So appreciate that support as a part of our program. I guess we are doing this format sort of virtually at this time, and I hope everyone continues to be well and safe. So I guess without further ado, I'll turn the virtual podium over to Jeff and team. So thanks again, Jeff.
Yeah, thank you guys. And here's hoping that this is the last virtual Spine Journal Club we have. Maybe the next one will be in a nice restaurant. I remember the last one that we had in person, I think, was in the basement of Teroni, and we all enjoyed each other's company in addition to good food and drink. So hopefully that's right around the corner for us. Tonight, I'm very pleased on behalf of my partners, Howard Ginsberg, Chris Whittu, and Henry On, to be hosting this journal club. Our fellows put a lot of effort into selecting and analyzing these articles for discussion. Tonight, our fellows represent 4 different continents. So I think that's a testament to the draw and the impact of U of T Spine Program in the world in modern day. And so without further ado, I think we'll get right into it. So the topic tonight is disc herniation, and it's one that perhaps sometimes we overlook. But one that I think is nonetheless pretty apropos and something that we encounter on a daily basis. So I'm just going to dive right in. So I think we're going to start. So I'll introduce the fellows individually, and then we'll get into the meat of it. So the first talk tonight will be by Dr. Johann Hofereiter. He's from Munich, Germany. He'll be speaking about the effectiveness of surgery to improve motor weakness, which is sometimes, I think, a topic at least I struggle with in terms of counseling patients about whether their motor deficits will get better after surgery. The second talk will be by Dr. Doron Edelman. He's from Melbourne, Australia. He'll be speaking about tubular versus open microdiscectomy for lumbar disc herniation. The third talk will be given by Dr. Martin Gagliardi. He's from Mendoza, Argentina. He'll be speaking about recurrent disc herniations, speaking about their incidence rate, risk factors, and outcomes. And then finally, the last talk will be given by Sho Akahori, and he's from Nagoya, Japan. And he'll be speaking about decompression versus decompression infusion for recurrent disc herniations. So without further ado, I'll turn the podium over to Dr. Johann Hofereiter, and he'll be speaking to us about effectiveness of surgery to improve motor weakness in patients with lumbar disc herniation. I think Dr. Finkelstein has just indicated, and I might have made a flub, I'm sorry about this. Dr. Doron Edelman is actually from Israel. Sorry, Doron, we've not had a chance to meet. I apologize. I thought you were from Australia, so my fault.
All right. So just share my slides, and is it okay? Everybody can hear me. So
yeah. So I might suggest, Johann, just I guess we have about an hour or so in total. So maybe. Yeah. If all the speakers could limit their talk to about an hour, sorry, about 10 minutes, and then we can have maybe 5 minutes for discussion.
Great. Okay. Awesome. Thank you so much for the nice introduction, and thank you so much for all to having the possibility of presenting here in a paper about motor function. And first, no conflict of interest here. So interestingly, quite often, I think we are treating disc herniations because of persistent pain. And within the fellows group at St. Michael, sometimes we had the discussion also, what is about other deficits, for example, motor deficit. And I had the impression sometimes the way I was trained, sometimes also give lots of attention also to motor deficits. And this study came across me first. This was published in Spine by a group from Austria back in 2017. And what they found out that surgery within a time frame of 48 hours result in superior rates of neurological recovery in the setting of moderate and severe motor deficits and people with lumbar disc herniation. And at this time point already, the group announced there will be another study in the future. And what may be a drawback was of this study is the follow-up rate was only 3 months. And the cutoff rate was kind of a little bit randomly chosen. I think they attached to a common sense that maybe cauda equina syndrome should be treated within 48 hours, of course. But as we don't have any data on timing, so they took this surgery. Let me just see if I can, next slide, here we go. And then they came up with, just recently, it was published in January this year, actually, and it's ahead of print in neurosurgery. And with the title, Motor Recovery Depends on Timing of Surgery in Patients with Lumbar Disc Herniation. This makes me quite curious. And just briefly, what is, I think, not about just the terminology of disc herniation. What we're talking about is essentially are these images. I think since 2014, as far as I know, we have a common saying what disc herniation is. It was first published like in 2013, and these nice pictures are from New England Journal of Medicine 2016. So a bulging disc we are not talking about. This is only where the annulus is just bulging over the normal space the disc usually occupies, but everything which goes beyond this, for example, here, a disc protrusion, where this part here, the base is broader than the tip of the protrusion is called protrusion, and the extrusion is kind where the biggest diameter of, there's a dog in the background, it's funny. The biggest diameter of the disc is broader than the base. It's called an extrusion, and there's also secretion, as you know, that's completely disconnected from the disc space. So the background about everything here is general. We recommend or reserve our treatment or our surgery for intractable pain. And usually we wait at least 6 weeks before we might see surgery as an option. And before we usually advise patients to have conservative treatment. The sometimes or quite often motor deficit is present, and there are numbers between 14 and going up to 80% in all the patients with lumbar disc herniation. So it seems really to be an issue, and that until now, I think it's really differs from hospital or from even from country to country. Maybe the time of this surgery is largely unclear, and recovery rates are very widely as well in literature. So usually primary caregivers and neurologists or neurosurgeons as well commonly indicate conservative treatment first, despite of motor weakness. And what is known that a significant proportion of patients do not really regain the functional status they had before. And like I showed you, the preliminary data suggesting that timing might be crucial in these times, in these cohorts. And the aim of the study I'm presenting here was to elevate the impact of surgical timing on the motor recovery, and also identifying maybe time window for surgery. So the methods they applied, patients were recruited retrospectively, and the follow-up examinations were performed prospectively. The outcome or the dependent variable was the recovery of muscle strength at follow-up, and they applied the MRC scale before surgery at discharge, and 6-12 weeks afterwards, and 1 and up to 5 years afterwards. So they had to try quite a reasonable follow-up time. And the main predictor variables in this study was muscle strength, preoperative, and timing of surgical decompression as independent variables. And they applied the unbiased recursive partitioning conditional interference tree as statistics. I was not so familiar with this, or I came across a couple of times for the statistical method, also like in defining some subgroups in spinal cord injury, for example. But just as a brief review about this method. So this is a test which is based on the regression model, and is based on sequential tests of independence between the predictors and a pre-specified clinical endpoint. And it divides a heterogeneous group of patients we have into more homogeneous group pairs in regard of the outcome. And the first step is usually that they look, or the algorithm this instance looks, is the predictor, like what we defined before, motor strength or time, has a significantly associated with the outcome, and if yes, so it splits the group in that way that the cutoff value is yielding for a very small or the smallest p-value. And the second step is after a significant split, that it calculates another possible split from the new subset of patients which are is created at this point. So they included a total of 390 patients, and they had a really quite good follow-up rate with 99.7%, unbelievable. And it's only one patient, obviously, which is missing here. Final follow-up was approximately 4 years, with a huge range between 1 year and 73 months. And preoperatively, they subdivided the patients in mild, moderate, and severe motor deficits. Mild was 4 out of 5 on MRC scale, moderate 3 out of 5, and severe was 2 or below out of 5 in the MRC scale, respectively. And patients who didn't display any motor deficit were excluded from this study. So what has the recursive partitioning technique done so far? So what they looked first is they had this homogeneous group, and then they did this split in regard of the outcome of the motor recovery. And what is seen is that obviously the preoperative muscle strength was a strong predictor for outcome. So if you have here, for example, as indicated, and motor strength below or equal to, it influences your recovery significantly. So they split this up in these two groups here, and they did another split. And if you look on the left side of the graph, for example, in terms of timing, and timing obviously has an big impact on recovery rate as well. And what the algorithm found here is a date, is a time frame of 3 days, which was identified as an unbiased cutoff for recovery. And the slope of recovery in patients who has a severe motor deficit is much better than these who were operated later after the 3 days. What you can see from this graph as well is also people who are doing better in terms of motor deficit pre-surgery, before the surgery, and obviously the time frame of surgery when you're applying surgery has an impact as well, but not as much as in the group with who were severely affected by motor deficit. So in other words speaking, what they did here is illustrating the change of muscle strength at the last follow-up, and they divided, as you can see, a group which was had surgery done before 3 days or equal 3 days, and after 3 days. And what is really striking here, what you can see is people or the subgroup, when you look at the severe affected cohort in terms of motor deficit, quite a substantial amount of people. It was 61% recovered from the motor deficit if they received surgery within 3 days, whereas in the other group with a severe motor deficit, when they operated later, nobody really recovered fully. They improved some extent, but nobody recovered fully. And I think this is the main message here from this slide. And even in people who are moderately affected, you can see rather everybody recovered fully in the early surgery group, whereas in the later surgery group, only 23.7% recovered. And they did a sub-analysis here also with the patients who had a mild paresis, which they declared as in the MSC scale as 4 out of 5. And obviously the slope of recovery here was better when they received surgery within a week, and their algorithm found like kind of a cutoff of 8 days as a predictor of recovery. And if you look at this slide again, in other words speaking, if you operate on the patients who had a mild deficit before surgery, rather everybody had recovered at follow-up time, whereas only 60% recovered like at follow-up with if you apply the surgery later, and at a substantial greater amount of patients just remains unchanged. Deterioration was not applicable because nobody deteriorated in these in the cohorts. So the key results and the conclusions are obviously preoperative motor function is one of the most important predictors for outcome at the end and for functional recovery at the end. And it seems to be that better or significantly better outcomes are achieved in patients who underwent surgery early. And what they concluded at the end from this study is early surgery within 3 days should be offered to patients with a moderate or a severe motor deficit, and also in patients with mild weakness. It seems to be reasonable not to delay the surgery beyond 8 days, or at least it ensures recovery. So they are pretty mild with the conclusion with this cohort. but more specific, addressing, I think, the cohort here who had a moderate or severe deficit. So this is the end of my presentation. I'm happy to discuss this paper now.
Johann, fantastic work. Very nice presentation. I guess maybe I'll start with asking you, so based on this paper, a patient comes in with acute onset motor deficits and say their power is kind of 4 out of 5. Would the evidence in this situation, and they have severe leg pain, say they have a foot drop and their EHL and dorsiflexion is 4 out of 5, would this paper support us taking them to the OR quite quickly, like booking them as a case or a B case, or waiting? What's your thought in terms of how we should interpret the evidence presented in this paper?
Certainly not. I think this is a group which is mildly affected, and as you have seen from the data, I think the data is not really strong about that. And they had this cutoff of 8 days in this subgroup of patients. But what is missing here, I think, is also a control group, right? So they hadn't a group which was kind of treated conservatively. What they claim is, if you treat the patient conservatively, it might not be the outcome not better than if you apply surgery within 8 days or even later or something like that. So it might be the same, but certainly there's no control group. And I think the effect is quite subtle here. We should, I think, more focus. I think the focus on with this paper is really on the people who are, or the patients who are severely affected by paresis, and they highlight that this is also should guide us towards surgery, maybe even quicker than we are used to it. And sometimes we don't have the influence because a lot of these things happen out of hospital, right? Like in people present to neurologists or to general practitioners with paresis, and I think until now it's one of the papers who addressing this so specific and like giving a clear message. And yeah.
Anybody else have any comments or thoughts on the paper? Any questions for Johann?
Yeah, it was really well presented. I think, the lack of the control group is a significant caveat, so one needs to be careful kind of with the presentation. But I think one of the messages, for me to maybe to reflect on it is, if somebody does come in early in their presentation with a significant motor deficit, to certainly consider the option of proceeding kind of early with surgery. And I guess it's for me, it would maybe be an option, to try to consider. The group that I sometimes find challenging are the patients who have resolved sciatica, but they come in with a complete foot drop.
Yeah.
And, what's the outcome there? And my experience with those patients is not always so great in terms of the return of the motor function. I see Albert shaking his head. I don't know what your thoughts are there.
I was just about to add that, it would have been helpful to get a bit more context in terms of their patient cohort. I mean, these are patients operated on urgently and not through a sort of elective sort of pathway, and, a little bit more detail about, how much pain were they in or not. And I fully agree with Michael. I'm challenged by the person that has a painless foot drop and what to do, and it's only been a few days, right? And so, generally speaking, I've been counseling my patients that generally we're a little bit more predictive of helping pain, a little bit more variable with regards to motor deficit, but certainly you want to provide the best outcome and obviously counsel patients accordingly and have realistic expectations, because some of the painless foot drops, and as Michael's alluded to, with surgery, you may not get them back to their pre-condition baseline.
Yeah,
Just have
sorry, go ahead.
No, I would have a question just to the audience. If anybody else addressing this in the future, again, for example, do you think the MRC scale is an appropriate tool to assess this thoroughful, or is it maybe still too individual? And sometimes it happens that, for example, the documentation is done by a resident or something like that in the emergency department, maybe in a rush and things like that. just want to share your thoughts about, because I think the topic's interesting, but if the MRC scale, and it was already pointed out, maybe alone is not sufficient to specify the groups which might benefit from early surgery.
You know, I use the Weber study, and I use that when I talk to all patients. So when they have numbness, weakness, and pain, I tell them surgery will most reliably relieve the pain. Strength will be the next thing to recover, and then sensation will be the last thing to recover. But if you look at the Weber study in an operative versus non-operative cohort at 5 years, there was no difference in motor recovery in patients who are operated on or not operated on. So, you know, you look at that study and you look at the results of this study, and, you know, there may be a different group, you know, a different, you know, I don't know what, you know, if there was like all acute sciaticas here that, you know, got into the OR and got their MR in 3 days. I don't know how everyone gets into the OR within 3 days here in this study, but, you know, this goes against the, you know, Weber study. So how would you rationalize that, or, you know, come to terms with that? Would you still tell patients they should go to the OR first, or we should wait, or tell them that you can expect equal recovery if we wait, or if we don't operate?
Yeah,
Sure.
I mean, I think you're right, Joel. Like this patient population is a bit unusual, or at least probably not particularly applicable to the Canadian healthcare system. Like these are patients who came in acutely, had their imaging acutely, had their a large proportion of them had their surgery quite urgently. And I just, in my practice here, most of what I'm seeing is what we've been talking about, is the residual weakness once the acute pain has resolved in the time period of weeks, sometimes months later, and the patients want to know, well, should I have surgery for this weakness now? My leg doesn't hurt anymore. What do we do? I think in our system right now, that's probably the more relevant question. I don't know. I think you see a patient who comes into the emerge with a significant foot drop and severe pain, and they're just not coping, and it's been a few days. I would certainly offer them surgery, and you know, the majority of them will take it, but it's just that scenario doesn't come up that often.
I agree with you, Chris. It doesn't seem that controversial. Like if somebody comes to ER with severe pain and sudden foot drop, and it's been a day or two, I think that most of us would offer the patient surgery and tell them it's an option, as Michael indicated. But no, we don't see that too often in our system. Carlo, I think you had your hand up. Did you have a comment?
Well, I think Joel spoke to that comment of the issue of the natural history of these conditions anyway. We don't have a good data on that. Also, the subjectivity of the testing is also an issue, particularly if they're not blinded and it's a prospective study. There's potential for bias. So I agree with Joel's comment in terms of the natural history, and long-term results and outcomes are similar whether they're operative or non-operative. Yeah, but great presentation. Thank you.
Totally agree. I think in the interest of time, we should move on. Thanks again, Johann. So the next paper will be by Dr. Doron Edelman, and he'll be talking about tubular versus open microdiscectomy for lumbar disc herniation.
Great, thank you. Thanks, Funny Book, for having me. Thanks, guys in St. Mike, for giving me a great topic to discuss. So, can you guys hear me? All right, connection is a little bit slow. So I'm going to be presenting a meta-analysis comparing tubular microdiscectomy and conventional microdiscectomy for lumbar disc herniation. So it's a growing topic in the past couple of years. You can see about the amount of books been reading, and this is all from the past 4 years, pretty much. So it's a really growing topic and interesting and sometimes emotional. But the concept of minimal invasive surgery is not a new one. It's pretty old, goes back a long way. This is actually, on the left side, this is from Kaspar in '77, and this is a drawing of a tubular approach. And you can tell that in terms of growing technology and skills, and the topic is the approach is gaining more and more in multiple ways to approach the spine from a sense of invasiveness and From the nose surgery perspective, at least back home, we used to have a saying, big surgeon, big incision. And lately it's becoming a big surgeon, small incision in that sense. So I'm going to present a meta-analysis comparing tubular approach and lumbar conventional. So it's a meta-analysis. The inclusion criteria was about 18 to 80, which has MRI confirmed disc herniation, which was single level and nothing, no more. They didn't include any other compression on adjacent level that can interfere, and only RCT that were looking into standard versus tubular. I must say that none of them looked into endoscopic approaches, so that were excluded as well. Like I said, spondylitic and any signs of instability, so no need for fusion, and of course tendinosis. Primary outcome were vast, of course, the ODI, SF36, and any that were any secondary cause as dural tear, reoperation, and any defeats that came out of the article. Of course, blood loss and operation time, which is a big topic in that sense, and length of stay that comes in terms of cost, but if cost wasn't in this article, you can see that in different articles. So out of around 600 articles, 300 were removed. Two reviewers looked into 24, and only 4 RCT were selected for this meta-analysis, which is probably one of the problems of the article, that they didn't really state why they're removed, and the sample size is actually quite small in that sense. So that's, without further ado, let's go to the results in terms of, and look over the forest plot in order to understand what's going on. But there was no difference between both of the approaches. In terms of ODI, there was a clinical significance that favored tubular approach. And the authors stated that the bias and the significance statistical was meaningful, but due to probably a low sample size, and which was one of the drawback of this article. SF36, no really difference between both the approaches, and physical function, pretty much no statistical significance in that sense as well. Secondary, in terms of dural tear, no real difference, and as well as repeated surgery. Operation time, they found 4 minutes difference between the approaches, which is not that significant, obviously, and length of stay. So overall, there was no really significance in this meta-analysis, and there was, the author stated there was a little bit problem in allocation and bias towards in the selection in one of the articles, and it was showed as well in a different article that came out a year before that in 2018. That actually included 7 RCTs and came up with pretty much the same result as well. So there are many ways to climb a mountain. This is K2. All ways are pretty standard, but you probably need to choose your own way and how to get them. Thanks.
Thank you. Excellent. So Doron, did they look at, I know some of the things that we've heard about, that tubular microdiscectomy may be superior to our length with respect to length of stay and infection rates. Was
No
that,
difference.
pardon me, sorry?
They didn't see any difference, and I looked over actually all the meta-analysis that came up for this herniation, and there was no difference between the 2 approaches.
Mm-hmm.
Not statistical significant results in that sense.
And also just a follow-up question. So in this meta-analysis, did they, were they at all selective, or did they perform any sort of sensitivity analysis based on the quality of the studies involved? Were these all RCTs? And if so, were they all high quality RCTs? And was there any attempt to focus kind of on the best evidence available?
That's why they came up with only 4 RCTs. There was a different meta-analysis a year before, 2018, that came up with 7. And there is one from 2008 that's one of the problems, that it was difficult to find good quality. And the biggest article that has 160 patients in it had actually a selection bias in that sense. That's why it wasn't always analyzed compared to both of the articles. And also SF36 wasn't reviewed in all the articles. It wasn't fully reviewed. That was one of the problems.
Interesting. Any comments or questions for Doron?
I have a question. What was the follow-up period of those points? The follow-up period for the outcome measures?
So it was 1 year, which is one of my problem with that. If I didn't check 3 months, 6 months, and 1 year.
Yeah, so we expect it to go, the regression to the mean and long-term follow-ups tend to get better anyway. You don't have a control group to see whether or not one is superior to the actual study.
I agree. I would do a longer period, and I will check 3 months, 6 months, and then a longer period. Doesn't make any sense. There is a follow-up article, but the RCT is not that good. So there's a problem with that. So I agree.
Great, thank you.
It would seem though that the results kind of seem to make sense though, that you're kind of comparing two different kind of microsurgical approaches, and I think it looks, and there's a lot of art involved to both. So it kind of would make sense. That doesn't kind of seem like there's a huge difference that's apparent between the two. I think Dr. Amendolia's point is quite correct, that you do lose a bit when you look that far out. It would be interesting to looking at kind of the trajectory of the recoveries, but there's also a big difference in the quality of some of the studies that was done, which was also, I think, Dr. Wilson's point. The ARTS trial was a very high quality RCT published in a very high impact journal. Some of the other studies were of lower quality as well. But in the end, that doesn't mean that the results are invalid, but sometimes doing a sensitivity analysis to see what happens if one study is omitted or the other. But to me, it just kind of looking at it doesn't look like there's a big overwhelming signal favoring one over the other.
I feel that there is a difference in, I would expect blood loss to be less in MIS approach. And probably with next year, we're probably going to have the same discussion just with endoscopy in the next couple of years. So it's a skill that needs to be learned.
Chris, I know that I know you do both. Can you give us your perspectives on the study and just kind of what you think, how it fits, the outcomes fit with tubular versus open?
Yeah, I think it's one, like Michael said, they're both microsurgical techniques. I don't really expect blood loss to be less with a tube versus open. I mean, most of the blood loss in a microdisc comes from the epidural venous plexus if you get into it. I think that probably 90% of my discs I do through a tube, but I basically do them because I find it actually easier, particularly if the patient's obese. It's a little bit faster and a little bit easier, and that's just my preferred technique. But I'm not at all surprised that there were no significant differences in this. And I think that and it does also come down to the fact that if you follow patients long enough, no surgery, which is the ultimate minimally invasive surgery, versus open surgery, that long-term outcomes are equivalent as well in disc herniation. So I think these results are exactly what I would expect. And I think it comes down to surgeon preference and surgeon comfort and training and culture and everything else in the decision making.
But really the outcomes that we would want to look at now, like everything evolves and we start looking at different things, we're always trying to refine things. So if you're going to be looking at and comparing this, what we're looking at is length of stay and how much analgesia you use in the recovery room, or the next day, like total morphine equivalent in the first hour or first day, or, the few days afterwards. I think that you don't expect to see any real clinical difference, but you do expect to see less, the results or the benefits of a less invasive approach with less pain, less hospital stay. And to that end, Doron, what was the hospital stay for these, for these two groups? Do you remember what the results were for this? The conventional?
It was between 1.3 to 2.9, but nothing significant. It was the difference between the 4 articles that were reviewed.
But I think hospital length of stay can be very cultural as well.
Yeah, exactly.
Like we have fellows come in who say, "Oh, our disc stayed for a week after surgery," and like we send them home the same day. And so, I think hospital length of stay I find to be a little bit of a challenge. But I do agree with you, Joel. Though looking at morphine equivalents in the post-op period is a good and important metric.
Right.
I don't think that was.
And I think that's what, we should be looking at, because, there's not much more to say about the different types, but those are what we're looking at now. We're getting more granular about how our techniques are, working, and that's sort of, the next level of success now. It's like, how little analgesia do we need after surgery,
Yeah.
Okay, excellent. So thanks again, Doron. I think we'll move on to the third paper, which is presented by Martin Gagliardi, and he's from Argentina. He's going to speak about recurrent disc herniation rate, risk factors, and surgical outcomes.
Hi, everyone. I know, can you hear me well?
Yeah, thanks, Martin.
Okay. Thank you for letting me participate in this journal, and Dr. Wilson and Dr. Lee for the guidance in getting these papers and analyzing them. So this presentation is about recurrent disc herniations, an analysis of rates, risk factors, and outcomes after revision surgery. Several studies have shown that patients that suffer from leg pain and sciatica have faster and superior long-term outcomes when treated with surgery versus conservative treatment. However, a proportion of these patients unfortunately may experience a recurrency in the pain due to recurrent disc herniation, and this recurrence is important for two main factors. In the first place, the absence of a reherniation is one of the strongest predictors of a good clinical outcome after discectomy. And in the second place, 6 out of 10 reoperations after discectomy can be attributed to recurrencies. The definition of recurrencies is quite varied between different in the literature. From textbooks, that recurrencies are disc herniation that can occur at the same level, same or opposite side, after pain-free relief time after the index surgery. However, some authors consider just only ipsilateral recurrencies, and other authors use different time periods between the index surgery and the recurrency, and other authors even describe an early recurrency and a late recurrency. Maybe because of this, the rates of recurrency are so different among literature, with papers reporting 3% of recurrency and others up to 20%. And besides the definition, some studies include only surgically treated patients instead of a recurrency seen in the images. So we don't have an actual number of the recurrency, but reoperation after recurrency. Several factors have been studied to try to predict the risk of recurrency in the preoperative, intraoperative, and postoperative settings. And some literature about this is a systematic review by Wang, who included 17 case control studies. And they observed that patients with diabetes, smoking, protrusion types of herniation had an increased risk of recurrency. Meredith in this retrospective analysis of 75 patients that underwent discectomy, observed that obese patient had 12 times more risk of having a recurrency and up to 30 times more risk of having a reoperation because of this. The same with radiological predictors in this systematic review by Brooks et al. That included 13 studies. They concluded that an increased disc height index, which is the proportion of the disc over the vertebral body, now modic type 1 changes and increased sagittal range of motion were related to increased risk of recurrences as well. In the intraoperative settings, there are two main factors that have been explored in the literature. First, the size of the annulus fibrosus defect, how large is the defect, is one of the main factors that have been studied. And in the second place, how aggressive are surgeons when they do the discectomy in terms of the magnitude of this resection. And this paper by Carriage et al. From 2003, who explored the outcomes in patients who underwent discectomy in 187 patients. And they tried to classify this herniation into 4 groups according to the presence of extruded fragments, the annular integrity, and the surgical treatment. And they observed that patients with with a fissure in the annulus fibrosus, like this group here, had a very low rate of recurrency, like 2% at 5 years, while patients with larger annular defects caused by the hernia itself, like this group, with recurrences rate up to 27%, and patients who required an extensive annulotomy with recurrences rates up to 37%. In further studies, the same authors studied the impact of more aggressive discectomies versus limited discectomies or herniectomies, and they found that although there was a slight non-significant lower rate of this recurrency in the more aggressive group, this group with subtotal discectomy had worse clinical outcomes, mostly in terms of lower back pain. So the authors could prove that surgeons somehow could change the recurrency rate, but at the expenses of worse clinical outcome. According to all these questions and issues about this challenging topic, we thought it was a good idea to analyze this paper about the reoperation for recurrent vertebral disc herniation in the sport cohort. The study focused on these 4 main questions. Number 1, what was the reherniation rate for the patients? If there was any patient or herniation characteristic that could predict recurrency, how were the outcomes between the reoperation and the index surgery in terms of clinical outcome and complications? And finally, if there were any difference in, between early versus late revision surgery patients. This study included both the randomized and the observational cohort of the sport, with patients diagnosed with lumbar disc herniation with radicular symptoms for at least 6 weeks, with images showing the hernia, with a consistent physical examination that had surgery via an open microdiscectomy, and they divided these patients into 2 groups. The reherniation group was any patient that underwent a second operation at the same level and side than the index surgery, and the no reherniation group that included patients that had no recurrence or had a recurrence but that was treated non-operatively, and maybe the decision of including this patient with non-surgically treated recurrences into this group could be a limitation that we are going to discuss later in the presentation. They divided the reherniation group into an early group and a late, using 1 year time as a threshold, and the analyzed primary outcomes including OS3, sciatica bothersomness index, and the SF36, and secondary outcomes including patient satisfaction, opioid use, and operative complications. In terms of the result, a total of 810 patients were included in the study that were follow up to 8 years, and 74 of them had reoperation due to a recurrent herniation in this frame time. They give us a rate of reoperation of 9.1%. Interestingly, more than a third of these patients had the recurrency in an early recurrence, which is less than 1 year of evolution. And almost all of them, 92%, had a decompression, a long surgery, and 11 of them had a fusion as well. About the factors that could impact on rate recurrency, they analyzed more than 40 variables, and in their multivariable model, they found that younger age, the lack of neurological deficit, both motor and sensory deficit, and the baseline OS3 index were independent factors of recurrency. In particular, younger age was the strongest predictor of reanimation, in a way that the rate decreased 4%, which with every additional year of age. Patient with an asymmetric sensory deficit had 39%, and patient with a asymmetric motor deficit had 46% lower rate of recurrencies. And finally, for every 1 point increase in the baseline ODI, the rate of reanimation increased by 2%. In terms of outcomes between both groups, interestingly, a patient that underwent a reoperation had a significant improvement in both, in every single primary metric, bodily pain, physical function, OS3, sciatica, bothersomness. However, the magnitude of this improvement was significantly less than those patients with the primary discectomy. Surprisingly, the reoperation group did not have a higher rate of perioperative complications, such as wound infection, CSF leaks, or neurological deficit. In terms of comparison between the late recurrency and early recurrency, there was no difference at 4 years follow-up between groups, not even in outcomes or even in patient herniation or surgery perioperative characteristics. We think this was a very interesting study to analyze, that we want to highlight two main limitations. In the first place, patients with recurrent herniation treated non-surgically were included in the non-reherniation cohort, and we think that maybe this could make that the comparison between the reoperation and the primary surgery could make the outcome even wider than was presented, because including allocating patients with reherniation into the primary discectomy. And secondly, there was a missed opportunity to analyze the difference between patients with recurrency treated conservatively and surgically. That could have been interesting. And in the second place, the study did not include analysis of the size of the annulus fibrosus deficit or the magnitude of this removal during surgery, that we believe are significant factors to predict recurrency. So the take-home message that I have from this paper is that the chance of undergoing a second surgery for recurrent herniation at 8 years is less than 10%. The younger patient might be somewhat a higher risk of reherniations. A reoperation will likely have good outcomes, but not as good as a primary intervention. And complications after revision surgery after recurrent herniation are likely to be similar for those after primary surgery. Thank you very much.
Martin, thanks a lot. Clearly, after working with me for 4 months, you've learned a lot about recurrent disc herniation. So I guess I'll just start. To me, the 9% recurrence rate seems to be low, and I think you hit the nail on the head. That paper defined recurrence as revision surgery, But what do you think, based on your review of the literature, including studies that looked at patients that came back with recurrent symptoms that may or may not have had surgery, what do you think the actual rate is?
I mean, I don't know about the number, but what I think is that there's a lot of patients that we don't know. They may have a recurrency, or maybe they are asymptomatic, or the symptoms are very low, that they don't come back to see us. And then we have this cohort of patients which we know they have another disc, but they go like conservative treatment. And then in the last we have a patient with a big recurrency that undergo another surgery. So I think we have these three different populations, and all of them are recurrency. But what I've seen in the literature is almost all papers that talk about reoperation after recurrency, as you said. I think the recurrency must be between 20%, 25%, I'd say, according to some textbook, some revisions that explore about immunological recurrency.
Yeah, it's interesting. Anyway, superb job presenting that. Open the floor to other questions or comments.
I agree that it was a very nice presentation. I think this is also kind of a shout out to the SPORT trial, which is really kind of a family of trials that have been spearheaded by James Weinstein, the former editor of Spine. So the number of these studies are landmark studies in the field. So it does merit kind of reviewing these. With regard to the actual kind of article, I think it's probably important to differentiate the patients that have an early recurrent disc herniation, which may kind of maybe suggest, a combination of some technical issues, maybe with the surgery not being aggressive with the discectomy, and maybe also some clinical factors, versus very delayed, reherniations at that level. I think you're kind of dealing with kind of different issues. So that's just really just kind of a comment or a reflection.
Yeah, that's interesting. I think the other interesting point that Martin raised is the size of the annular defect. And it's, it seems that perhaps these patients that come with huge annular tears and a big extruded disc, say in the setting of cauda equina syndrome, may have a higher risk of recurrence because there's just nothing keeping the disc material in place. Carlo, I think you had your hand up.
Yeah, thanks. Thanks, Martin, for a great presentation. Just two comments / questions. First, the factors that predict recurrences, one being minimal loss of sensory or motor at baseline. I can understand age, because as you get older, the discs lose fluid and maybe you have less herniation. But how would you explain loss of sensory or no loss of sensory or motor as a predictor? It doesn't seems counterintuitive to myself, but what are your thoughts on that?
To be honest, I don't know. And the authors in the paper, they, as you said, they say we have a rational explanation for younger age, because this may have more nucleus pulposus material, and we are dealing with healthy discs that have a herniation. But I think there's some explanation for this difference between people with and without neurological deficit. I think that maybe there's a technical difference. Maybe patients with a neurological deficit have bigger discerniation, so maybe the annular feature is less, is smaller. I don't know. To be honest, I don't know about that.
Yeah. The last comment was quite surprised in the paper that they only included, in terms of occupation, whether or not they're lifting at all. But what we know in the literature, vibration and like truck drivers and people that use heavy machinery are very high risk for recurrent disc herniations, but didn't include that as part of their baseline. So any comment on that?
They included that in the univariate analysis, and they saw that there was a small trend toward higher recurrency in that population. But when they, and I don't have the statistical knowledge to make an answer. But when they did the multivariate analysis, they couldn't prove that the lifting in the post-operative setting could significantly impact the recurrency rate. However, I think the literature is quite sparse in terms of how to go back to work or what kind of activities. I found some papers that patients go back immediately after surgery to work, and the rate of recurrence is pretty much the same, while other papers claim that heavy lifting, exercising, and specific activities can definitely increase the risk of recurrency. So I don't know why that happened.
Howard, you had
so much. Thank
you
you.
had your hand up?
Yeah, just I guess a comment about the technique of the annulotomy that you do and the impact that could have on it. My practice over the years, I've made it smaller and smaller, and now I just make a little tiny cruciate incision and push down to kind of forcefully herniate out the bulge, as opposed to doing a big annulectomy where you're leaving an open defect. And so I don't know if that has an impact. I just instinctively have done that. I think it would be difficult to study. And then the other question would be like, what about the impact of annular repair, which I know wasn't in that study, but just what your thoughts are on that.
I've seen, I read a few articles about annular repair, and there are some RCTs that claim that some devices could, in patients with large annulus defects, may reduce recurrency, but I'm not sure about some bias that those articles may have. And there's some biological studies as well in terms of how to repair the annulus, but I don't have any experience on that. I don't know what are your thoughts.
What about the technique of how you cut the annulus? I've seen a lot of different variations on it.
Yeah, to be honest, I always try to do like a limited discectomy, even an herniectomy whenever possible. And as you said, try to do the less disruptive incision over the annulus fibrosus when I do a discectomy. I think that may have an impact on recurrencies. Yeah.
I think that, I think there has been at least one good study that I know of that randomized patients to complete discectomy versus sequestrectomy, basically just limited discectomy. And then Martin actually showed that study, right? Which showed that maybe the rate of recurrence was lower with a complete discectomy where you curette the end plates almost like you're doing a TLIF. The rate of recurrence is lower, but the clinical outcomes are worse with respect to back pain.
I'm just more talking about the incision you make in the annulus, how to get the bulge out. It just instinctively seems if you make a smaller cut, you're less likely to get a recurrence because you left a smaller hole. I just don't know if that's true or not.
Yeah, I think it makes sense. I think the challenge is though that like that sort of approach may be really useful for an acute soft disc herniation where you can kind of pop the pimple, so to speak. But when it's like a calcified disc that's more chronic, for me anyways, it's hard to do a good decompression without making a pretty good annular opening. So I think it's a great point though. Anybody else on the call tonight have any thoughts about technical ways to minimize recurrent disc herniation?
Yeah.
Sorry.
I think Jeremy had his hands up first. So Jeremy, do you want to go ahead first, and I can follow?
No, I think a couple of years ago was the Journal Club that we started talking about the difference between a discectomy and a fragmentectomy. And I like the concept of describing it as a fragmentectomy because I think in my mind, you're just looking after the unstable disc fragment versus trying to create a big hole and taking a lot of disc material out. So I think that the points are well taken. Howard stole my thunder with a question about repairing the annulus. I'm not I think the jury's out. I think I'm not convinced. I've done about maybe, I don't know, a handful, maybe 12, but I'm not convinced it really helps, but we'll see. But I think the minimal discectomy and the technique to get there probably makes the most difference.
Yeah, and I'd sort of probably echo the general, it's a bit of a pet peeve of mine. I mean, when we do all these trials, we sort of lump apples and apples and think they're apples and apples. And as we're hearing with this discussion, all these sort of lumbar discs, particularly in terms of their anatomical location, structural changes, and intraoperative findings and techniques, there's a little bit of variation that I think really warrants sort of additional study. And I certainly agree with the group. I mean, there's those sort of broad-based discs that you get in there. You do your lateral recess decompression, and then you're sort of struggling, well, do I poke a hole in this, or did I, dorsally adequately decompress it or not?
Yeah.
And, I agree with Howard that, over the years, I've certainly been trying to be less sort of invasive and all of that. That's very different than going in and taking out an extruded fragment that's no longer sort of even connected at this level, and you don't have any issues to sort of worry about. And those are, I think, some of the anatomical characteristics that we're just not capturing. I mean, we're so focused on prems and those sort of measures, which are clearly important in neurology and things like that, but those are all secondary to the genetic makeup of the patient, as well as the as well as some of the anatomical things I think we could sort of potentially benefit characterizing a little bit further. And I think conceptually, at least, to try to sort of preserve as much physiologic functioning of the disc and whatever remaining disc material that's there, if you're not fusing it, is sort of something to sort of be a goal. But again, there's still a lot of questions that remain unanswered. Although I think clearly we're sort of getting a sense there's a lot of experience, certainly in this room, that I guess hypothesis generating, and it'd be great to sort of study more comprehensively.
I think you raise a good point, Albert, though. I mean, we get quite focused on the discectomy component, which I think is obviously very important. But I think another point is a thorough lateral recess decompression, unroofing the nerve root, creating a lot of space in that anatomical compartment, such that even if there is a bit of a recurrent disc, perhaps the patient tolerates it more, or it's less symptomatic. I think that's another kind of a principle to abide by. Any other comments or thoughts on this paper? Okay, great. I think then we will finish with the last paper. Bear with me here. So I believe the last paper is presented by Sho Akahori, and he's talking about decompression versus decompression and fusion for recurrent disc herniation. Sho, take it away.
Yes. Can you hear my voice?
Yep.
Hello. I am Sho Akahori, fellow at St. Michael's Hospital. Thank you for letting me join this journal club. So my today's topic is how do we treat recurrent lumbar disc herniation. This is a basic diagram of how to deal with a basic first disc herniation. Conservative treatment is tried, and if the pain and other symptoms do not improve afterwards, various treatments are considered. So if the patient has a lumbar disc hernia without instability or spondylolisthesis, we usually choose open discectomy or endoscopic surgery. But if the patient has a lumbar disc hernia with instability or spondylolisthesis, we perform fixation surgery. So if recurrence occurs after decompression surgery, the choice whether performing decompression only or fixation surgery again and fixation surgery is very difficult problem. The choice is based on the surgeon's experience and the patient wishes. Therefore, I choose this paper to see if there is a difference in the result of decompression alone versus decompression and fusion for first recurrent disc herniation. The incidence of recurrent disc herniation defined as disc herniation at the same intervertebral level with a pain-free period of at least 6 months after primary discectomy or decompression has been reported to be between 0.5% and 25%. There are no guidelines to help surgeons determine which procedure is more appropriate to treat recurrent disc herniation. Some authors recommend discectomy in patients with radiculopathy alone, while fusion is recommended in the presence of lumbar instability, radiographic degenerative changes, and/or chronic low back pain. A study reported that high-volume surgeons, over 200 cases per year that have been in practice longer, 15 to 20 years, were more likely to do a fusion larger than a repeat decompression surgery. So the literature purpose, the purpose of this study is to compare baseline patient and radiographic characteristic and 1 year patient reported outcomes in the patient who had decompression only to patients who had decompression and fusion for recurrent disc herniation. About the methods, there were 54 cases of decompression only, 40 cases of decompression and fusion. The authors collected demographic items, radiographic items, surgery outcomes, and outcomes measures as measurement items. The extent of facet resection was determined by comparing the width of the resected facet to the width of the contralateral facet at the level of decompression expressed as a percentage. This is a summary of demographic, radiographic, and surgical data. There is no difference between the two groups in terms of demographic items and surgical level. In particular, there is no difference between the two groups in terms of the presence or absence of lysis. There is no difference between the two groups in terms of in particular, there is no difference between the two groups in terms of the presence or absence of lysis and the postoperative facet resection rate. But as expected, there is a significant difference between them in terms of estimated blood loss and operative time and length of stay. Decompression and fusion group is longer and more than decompression only in the term of them. This is a summary of patient reported outcome measures. There was no difference in preoperative postoperative pain or improvement in symptoms between the two surgical methods at 1 year postoperative. So discussion. The currently study shows that improvements in multidimensional patient reported outcomes are similar for patients treated with either approach. Only one comparative study has shown greater improvement in pain score in patients who had a fusion. In this article, the rate of revision is the same between two groups. 3 patients in the decompression group required revision, 2 for second recurrence and 1 for foraminal stenosis. There is no additional fixation surgery patients. And 2 patients in the decompression and fixation group required revision, 1 for non-union and 1 for adjacent segment disease. The result of each surgery method does not depend on the presence of lysis and back pain. So it was reaffirmed that evaluating lumbar instability is a challenging problem. So usually instability is measured on dynamic X-rays with dislocation, rotation, and kyphosis as what is considered unstable. Sometimes we consider change signal in articular or lumbar disc as instability in MRI or CT. This is another paper, and this paper examines the extent to which instability and slippage need to be assessed operatively, but there is no difference in results between the fixed and unfixed surgeries in patients who has lumbar canal stenosis with spondylolysis of over 7 millimeters. This means that instability may not need to be considered in the choice of surgery. Limited this study. So this is not randomized study. Variables that lead a surgeon to choose decompression alone or decompression and fusion remain unknown and can lead to selection bias. The possibility of the extent of facet resection in other planes may be underestimated. The size and location of the disc herniation was not included in the analysis. And also the dynamic X-ray has not been examined and the actual instability cannot be measured. And longer follow-up would have been ideal to determine if fusion results in a more lasting improvement or less revision surgery that decompression alone or does not add any benefit. Conclusion. For the first episode of recurrent disc herniation, surgeons can expect similar outcomes with the patients are treated with decompression alone or decompression and fusion. That's all. Thank you.
Great presentation, Sho. So I guess we'll just ask you, maybe with most of the people that you've worked with in Japan, would it be commonplace for surgeons to offer fusion with the first recurrence of disc herniation, or most of the time wait for the second herniation to happen or secondary herniation? What's the most common thing you've observed in Japan?
In Japan, we always perform just only decompression surgery for the recurrent disc herniation. But if there is an instability in dynamic X-ray, we sometimes choose fixation and fixation surgery for the patient.
Yeah, I think in terms of, I mean, I know that there are these guidelines from NAS on the topic of lumbar fusion and when to offer fusion and when not to offer fusion. And from what I recall, I think it was the recommendation was after the second reherniation to offer fusion. And certainly, I think my practice would be similar to what you've suggested. Anybody on the call have any thoughts? Are people oftentimes offering fusion after the first reherniation? What do people think about this?
I would rarely offer a fusion after the first disc herniation unless a patient had clear evidence of instability.
Yeah. What about, I mean, what Dr. Fehlings, what would be your threshold? I mean, in your practice, is it kind of what the NAS guidelines suggest? If the person presents with a second reherniation, then that's an indication that that the patient needs a fusion, or is it more individualized than that, even after another reherniation? Do you think you really have to tailor it to the person and to the individual circumstance, or would two reherniations pretty uniformly mean a fusion in your practice?
Well, Scottie Pippen, the famous Chicago Bull, had 7 microdiscectomies at L5S1, no fusion. I'm not saying that's necessarily indicative how everybody would practice. Look, after the first recurrence, I discussed the possibility that some people, may develop, further degeneration of the disc and may go on to fusion. Most of those patients, fortunately, do not. And then I think with the second recurrence, I think that's when you start having a serious discussion. I wouldn't say that I would necessarily fuse everyone, but I would really, start looking at it pretty carefully and then assessing how much axial back pain patients had, evaluating carefully for some signs of, instability.
Yeah, it's interesting. I didn't know that about Scottie Pippen. Tiger Woods, I think, has probably a bit of a similar story, but I guess he ended up having a fusion. I guess for me, I would say that this study isn't, it's a bit, it wouldn't fit with, I think, most North American practices. I think maybe a more interesting study would be what to do after the second reherniation, whether or not there are major differences between doing a third microdiscectomy versus a fusion. Anybody else have any thoughts about this paper or this clinical problem?
No, I apply the baseball strategy with 3 strikes you're out. So first disc, laminectomy, discectomy, second disc, laminectomy, discectomy, third disc, I offer TLIF.
Yeah, I think, when you get into revision surgery, I think the patient counseling is going to be critically important. And even with a revision discectomy, I mean, there's those that are more challenging and those that go a lot smoother. And sometimes it's fully hard to predict sort of a priori. So certainly at the second or third, I start talking to the patient that, there may be some findings intraoperatively if there are concerns about stability. I would get sometimes consent for possible instrumented fusion, and sometimes I'll do a CT scan to see how much bone has sort of been resected from before. Because invariably you're going to be taking a little bit more tissues to make sure that you do things as safely as you can. But the degree of epidural fibrosis and the challenge of the case can be quite variable.
Yeah. true.
Fortunately, that decision-making is not too frequent, hopefully, for most of us. Third time operation in the same spot, but it happened to me today in clinic. So I had to make that decision, and I did offer the patient a fusion.
Yeah. And I guess it also,
You're thinking about, is there going to be a fourth operation at the same level?
Yeah.
You know, and it gets harder every time you go in there.
I guess that's the other point is after 2 operations, I mean, it becomes difficult technically to, I mean, you almost have to remove a lot of the facet joint or the whole facet joint in order to access the epidural space and the ventral epidural space to get at the disc. So it's almost becomes a matter of necessity in addition to hopefully prevent another issue at that same level. So
My question is, do we have any data that suggests that these patients that do have so-called instability don't do as well non-operatively, or like what's the data suggests? I know from an experience perspective, you can look at that disc and having patients come in recurrently for disc herniations, but what's the data suggest around long-term with these patients who say don't have surgery? Do they end up having more symptoms and more complications than surgery alone?
I think it's conflicting. I think if you look at Raj's papers, he'll tell you that you shouldn't fuse them even if they have instability, because mild spondies do better with the decompression alone than fusion. But that goes against some of the other data that's been historically quoted in literature.
Carlo, I guess I don't, so you're saying if a patient comes back with a recurrent disc, is there evidence to support that we should be operating at all?
No, fusion.
The first time or the
whether fusion improves the, they come back again for another disc herniation, and you suggest that fusion might be maybe the treatment of choice here. I'm saying that if you didn't fuse them and did another simple discotomy, what would the outcomes be?
I think that was kind of what the paper of Sho's was.
I think he's saying if the patient has instability, and you don't fuse it.
That's right. You don't have, because there's a lot of controversy around this instability. All the papers that I've read, whether you have instability or don't have instability, how do you measure it, and whether it's meaningful, and whether it makes a difference in surgical outcomes. It seems to be all over the map when you look at the literature. And my question is that if you do have instability, does that mean that if you don't fusion, these patients are going to end up being worse?
I think that's a bit of a difficult question to answer based on the evidence. I mean, I guess I would point to the SLIP study that was, I mean, it's not related to a disc herniation, but it's related to patients with degenerative spondylolisthesis who were randomized to decompression versus decompression and fusion. And the quality of life outcomes were better in the fusion group versus, the decompression alone group at 4 years. But, I think most people would, if there was clear dynamic instability on x-rays, if the patient had a lot of back pain, which sounded mechanical in nature, combined with that, I think most of us would have a low threshold to fuse. But I think there are probably circumstances, patient factors, which may compel us not to. But I don't know if there's a great evidence base for what I'm saying.
There's an article that I think Albert, you may have brought to our attention, or one of our colleagues through you, around kind of some of the basic science implications related to the significance of the annulus with regard to degeneration of the disc, and there's potentially some implications around kind of recurrence. It's more of a basic science paper. I think it was in one of the Nature subjournals, but I think Nadia, maybe you could put that article up in the chat. I think Albert you had suggested, we might want to discuss it, but there wasn't time this evening to do that. But I just think it is kind of interesting. So, I've never done an annular repair. Wasn't really kind of part of my my teaching, but it is interesting to consider. I would just be interested just to see a show of hands here among the surgeons on the call, like who has done an annular repair before for when they've done a discectomy? Jeremy, you have, and Albert.
Yeah,
Or
but
a
it's
trial. Sorry.
yeah, I think as Jared mentioned, it's as part of you know, basically an investigation, and we're, you know, tracking and following patient outcomes. There's certainly you know, a literature out there, and there's a variety of devices that can be utilized. The review article I suggested was more of a broad sort of translational paper, so it talks, and I think one of the fellows who spoke about a little bit earlier in terms of, you know, the challenge that we're dealing with is the degenerating disc and you know, and/or insufficiency, and we know, you know, biomechanically, and you know, there's even you know, studies in terms of discography and annular puncture and those sort of causing degeneration. And so you know, the disc is designed to sort of withstand you know, cyclic, you know, hydrostatic loading. That's primarily the mechanics of the nucleus pulposus, and the annulus is really to prevent those sort of tensile forces to allow the hydrostatic nature of the disc to have its physiologic functioning. And so whatever we do, whether it's a biological repair or an annular repair or other strategy that's not a fusion, is aimed obviously to try to either maintain or slow the degenerative sort of cascade. And then if not, then we get into this discussion about, you know, should we fuse or not, recognizing that we really don't have a great total spinal motion segment replacement even as yet, unlike some of our, you know, other joint conditions that we manage, such as hip and knee, for example.
Yeah, it is. It's interesting. And then there's the whole kind of futuristic discussion, you know, is there, you know, going to be any role for you know, for stem cells, for example, to, you know, to repair the disc once it's, you know, degenerated.
Yeah.
Because, you know, for many patients, the disc, you know, sorry, go ahead.
And this is, I think, where Mark Irwin and his group, you know, and others have sort of looked very closely into it. And, you know, when you're starting to think about injectables, and I think there's certain trials that are, you know, phase 1 human trials that are ongoing. You're either injecting something or you're delivering some tissue engineering sort of construct or some combination thereof of cells, bioactives, and some sort of scaffold. And so if you're going to deliver it, there's going to be two sort of approaches. You're going to have that patient population that's got degeneration without other issues that you're just going to inject in, or you may have this other group of patients, such as you know, patients that we've done discectomy on. You're there's an annular defect. Why don't you do something to the, you know, the disc and the nucleus pulposus while you're there? You know, stabilize the disc on the way out, because this current situation is sort of relatively unsatisfactory, as sort of clearly highlighted in terms of our discussions about recurrence and revision surgery.
Well, thanks for drawing that translational article, you know, to our attention. I would kind of commend it to everyone. It's got, it was interesting from my perspective to a learning perspective. Well, we're I think hitting kind of the end of our time, and you know, Jeff and all of the fellows, thank you very much for a fabulous journal club. Very really good topic. I think very common topic, something that we often take for granted, but we treat commonly, and I think it kind of highlights many areas of uncertainty, knowledge gaps, some of the challenges that all of us face in the clinical management of these patients. So thanks a lot.
Thanks a lot, everybody. Great job, guys.
You know, thank you, Jeff, for leading this from a faculty perspective, and thanks to the fellows.
Have a great night, everybody.
Thank you.
Good night. Good night. Thanks, everybody. Good night.
Thank you. Good night.